we are very proud that during this challenging time, the best of the academics is possible virtually. So I invite you all, and this session is a very important session on OADs, and the topic assigned to me is a very interesting topic. What we have observed the behavior of our patients during this pandemic, and how the oral drugs, especially the combinations, have gained popularity. And this study, what I'll be quoting, is none other than by Professor Ashok Das, who is the patron and the scientific chairman of this event, and also he, along with Dr. Sanjay Kalra, who is the past president of Endocrine Society of India and an innovative mind in the field of diabetes and metabolism in the country, was there. So I'll show you a survey what has been conducted during the pandemic time, which drug has been mostly used, and what is the rationale. So low dose OAD combinations in current pandemic. You know, a pandemic came, and the most sufferer are the patients who have chronic ailment like diabetes, because not only they had the comorbidity which can expose them to severity of the disease, but they could not consult their consultants, could not come to the clinics, could not come to the hospitals, and then we wanted that they should be safe without hypoglycemia, without hyperglycemia, without coma, at least during the period of pandemic, which was anticipated for 6 months, 1 year or longer. So starting with this study, what I was telling you, the fixed dose combination in management of type 2 diabetes, the expert opinion from an international panel by Sanjay, Professor Dash and others. This is from Southeast Asia, the Middle East and the Africa, and they published 8th and 9th February. The combination therapy is a useful strategy in diabetes management. In addition to a low-dose non-insulin anti-diabetic drug to monotherapy can improve drug efficiency by 80%. That's what the conclusion or the take-home of the study. The fixed-dose combination has some advantages over individual therapy. That's increased patient adherence due to the reduced complexity of the dosing, the greater efficiency, the cost advantages, and the Indian mind searches these points, how it can be more cost effective, and I'll take less number of doses. So the double fixed dose combinations such as metformin and glimepiride combination provide better glycemic control with good durability versus metformin and sitagliptin combination as seen in the START study that all of us know. So the fixed dose combination available in the US and Europe in type 2 diabetes are quoted here, like with metformin sulfonylurea, metformin with maglitinide, metformin with DPP-4 inhibitor, glitazones, and the glitazones with sulfonylurea. Mostly metformin-based combinations are available, and also glitazone sulfonylurea are available, and their different characteristics are listed here. The metformin-containing fixed-dose combinations are with sulfonylurea, which may be glibenclamide, glipizide, gliclazide, or glimepiride. It may be DPP-4 like Sita, Lina, Saxa, Teneli, Vilda, all like SGLT2 inhibitors like empagliflozin, kinagliflozin, and dapagliflozin. The glitazones like Pio, the alpha glucosidase inhibitors like voglibose and acarbose, DPP-4 inhibitor like the linagliptin and the empagliflozin combination. So along with metformin, all these combinations are available, are used, and well accepted by our patients. If you see the triple fixed dose combinations, it can be metformin along with sulfonylurea, and along with that either a glitazone like pioglitazone or alpha glucosidase inhibitor like voglibose. And you know how popular these combinations of voglibose, glimepiride, and metformin, or pioglitazone, glimepiride, and metformin in India with the patients and with the physicians. Let us see the evidence on use of an anti-diabetic agent in times of COVID-19. Metformin will be covered in detail by Professor Sahu in the next talk. Just touching upon it, has demonstrated protective, anti-proliferative, and immunomodulatory effects. decreased mortality in lower respiratory infections, significantly reduced mortality in women with obesity or type 2 diabetes in observational study from individuals hospitalized with COVID-19, and metformin use was associated with nearly 70% reduction in mortality in people with diabetes and COVID-19. That's a very interesting data. Many were impressed that a oral drug, how it can decrease the mortality. The risk of lactic acidosis was theoretical, mostly what we have seen, and may offer the cardiopulmonary protection in COVID-19 by enhanced S2 expression, can be continued in mild to moderate COVID-19, and it has to be avoided in severe or critical stage where we stick to only insulin. So the SGLT2 inhibitor and GLP-1 receptor combinations, if you'll see, the SGLT2 inhibitors increase the S2 expression in kidney, and risk of dehydration and diabetic ketoacidosis was there. It can be continued in mild COVID, but the dose reduction and the discontinuation in moderate to severe COVID and the critical stage was advocated, and dehydration was also a big challenge in this situation. The GLP-1 receptor agonist, the most important thing is the liraglutide increase the S2 expression in lungs and heart and the risk of vomiting. It can be continued in mild COVID-19, dose reduction, discontinuation in the moderate and severe critical stage. So say it be GLP-1, say it be SGLT2 inhibitors, which are very friendly in atherosclerotic cardiovascular disease, heart failure, in diabetic kidney disease, and many other situations, were not proved very useful in this pandemic situation. Let us see about the thiazolidinediones and modern sulfonylureas. There are a lot of combination taking these drugs as well. They also increase the S2 expression in liver and lungs. Risk of volume overload is there. It can be continued in mild COVID-19, and dose reduction and the discontinuation in moderate to severe critical stage. You will see the modern sulfonylurea, there is no evidence for or against the use in COVID-19. And those may have to be adjusted based on the glycemic control. There was a risk of hypoglycemia, but it can be continued in mild to moderate COVID-19, and in severe and critical stage, we preferred insulin. So if you see the common drugs like glitazones, like SGLT2 inhibitors, like GLP-1 agonist, they were not very safe, and coincidentally, all of them increase the S2 expression, which is the receptor which was enhancing the viral entry in the cell. And especially in the liver and lung, the S2 expression was increased with thiazolidinediones, with SGLT2 inhibitors, as well as the DPP4 inhibitors. But modern sulfonylurea, we didn't get any advantage, but we didn't get any disadvantage as well. And metformin had a clear advantage and a mortality benefit also, as I have already shown from the beginning. So let us see the insulin and DPP4 inhibitor. This can be continued at any stage. Insulin has the advantage, and especially critically ill patients who have put on insulin. It's the mainstay of the treatment for hypoglycemia in severe critical stage of COVID-19, and the dose adjustment to be done appropriately to reach therapeutic goals according to the diabetes type, comorbidity, and health status. So insulin, the molecule which is there with us for last 100 years, recently we celebrated the 100 years, and this is the molecule which has the advantage of always working. And the DPP4 inhibitors, it may hamper the sustained cytokine storm and the inflammation in the lungs. And sitagliptin treatment reduce the mortality and improve the clinical outcome in multi-center case control retrospective observational study, which was there for a reference. So surveys conducted among doctors in India, I'm telling you the changes in preference of doctors in the India amidst the COVID-19 pandemic. What happened during this situation, how we went in this situation. The most important data we have got is the OAD molecule preferred by the Indian clinicians during COVID-19, where modern sulfonylurea like glimepiride and metformin fixed dose combination. I told this is a questionnaire conducted across the country, and you can see In this population, almost 79.7%, almost 80% physicians preferred combinations like glimepiride and metformin fixed dose combination. So DPP-4 inhibitor combination were preferred by only 53%, metformin in 39.2%, insulin in 37.3%, the glimepiride in 24.2%, and SGLT2 inhibitor in 18.3%, glitazone in only 8.5%. So most of the physicians have preferred oral drops, that too in combination, and taking the modern sulfonylurea and a metformin fixed dose combination, and the as high as 80% people have preferred that. The reasons for glimepiride and metformin combination featuring on the top. The most important reason was the good glycemic control with less intervention, only a single pill, good glycemic control, and the almost 20.3% physicians gave the reason of good glycemic control, and the other important cause was it can be safely prescribed along with the insulin and other OADs. Even if we added other drugs as a backbone therapy or a baseline therapy, the glimepiride metformin went along. Besides, the cardiovascular safety, less hypoglycemic risk, and the weight neutral benefits were there. And most of the physicians responded all of the above. That's starting from the glycemic control to the weight neutral, less hypoglycemia, cardiovascular safety, and then safely combining with other drugs were the reason that they prefer this glimepiride metformin combination. The increased usage of low dose glimepiride, that's 0.5 per 1, along with metformin during the pandemic, you will see the majority of the physician, almost 84.5% have shared yes to this, and the top reason for increase in use of this low dose glimepiride metformin combination almost in 50% patient was the efficacy safety, and we have discussed about the others, that's the no risk of hypoglycemia, affordability, and wide availability. The preferred patient pool for the use of low dose glimepiride metformin combination were majority in 32.2% in newly diagnosed diabetes. Here let me tell you, in many patients we have suspected the viral invasion of pancreas and ileitis because many of them have turned diabetic post-COVID or in the long COVID follow-up. And here the most important factor in this newly diagnosed patient who don't prefer to be on insulin at home or with mild to moderate infection were very comfortably treated with this combination of low dose glimepiride 0.5 per 1 along with metformin. And this almost 28.8%, 29% patients who were marginally uncontrolled with existing therapy were comfortable with this combination. The next common indication was early stage of diabetes and elderly type 2 diabetes, and then other small association with long duration diabetes with comorbidities and the type 2 diabetes with hepatic and renal impairment. So I'll tell the preferred patient pool are this, and this combination was similar to gliptin combination, was responded by majority of almost 62%, and then maybe by 16.6%, and need more evidence by 14.2%. No is only 7%. And why we can prefer low dose sulfonylurea? The reason I have already shown you, and this is the pandemic, the efficacy similar to gliptins, no or low risk hypoglycemia, weight neutral, affordable, and accessible. So before we conclude, I'll show you some evidences, the differential dual mechanism of action, low dose glimepiride, and this summarizes the action in the pancreas as well as the action in the peripheral cells. The remarkable peripheral sensitizing effect caused by the down regulation escape of the insulin receptors, 63.5% reduction in HOMA-IR, no beta cell hyperfunction and resultant hyperinsulinemia, and improves the beta cell function by 164.5% and improvement in HUMA beta cell as well. And the global evidence on the low dose modern sulfonylurea are published by many journals, starting from our own JAPI, the Indian International Journal of Endocrinology and Metabolism, Endocrine Journal, Clinical Medicine and Research, the Open Journal of Diabetes, the American Journal of Therapeutics, and the William Textbook of Endocrinology all have endorsed this low dose modern sulfonylurea combination. And this low dose glimepiride remarkably effective. I'm quoting the chapter from International Endorsement, the William Textbook of Endocrinology, which all of you follow. It shows the small dose of sulfonylurea, 0.5 to 1 milligram of the glimepiride with 2.5 milligram of extended release glipizide, either of the sulfonylurea, are remarkably effective, particularly in patients receiving the concomitant insulin sensitizing therapy, and are almost uniformly well tolerated. So this is what the William quotes. And if you see the effectiveness of this 0.5 glimepiride plus metformin, starting the low dose therapy of sulfonylurea metformin, the first Indian study using the glimepiride 0.5. If you see this study design, and initiating a combination therapy of glimepiride 0.5, metformin 500, and considered suitable for the management of early stage of type 2 diabetic patients. The important finding is the low dose glimepiride, the 0.5 milligram, significantly reduced the insulin resistance, HOMA-IR, and improved the beta cell function, which is the HOMA beta. And this study clearly concludes the low dose glimepiride may not add an extra burden to beta cell and leading to the stable glycemic control, and it's published in the Open Journal of Diabetes. The low dose sulfonylurea proven effective and safety tolerability. The combination sulfonylurea 1 milligram per day with DPP-4 inhibitor, 50 milligram sitagliptin per day improved the glycemic control with no reports of hypoglycemia or change in the body weight, which is published in the Journal of Clinical Medicine and Research. And low dose glimepiride proven durable as an add-on to sitagliptin. And you can see in this study published in the Endocrine Journal, the combination therapy is both safe and effective for the glycemic control without dose dependency over a period of minimum 6 months. So the place of low dose sulfonylurea and metformin combination, where can we place it? This is from our own JAPI, and 50% diabetic patients were on low dose glimepiride and metformin combination. 1/3 of them were younger population below 44 years, and around 17% were elderly. Type 2 diabetes and glimepiride 0.5 and the metformin 500 milligram combination. 64% or 2/3 of the patients either newly diagnosed or less than 5-year duration were only 0.5 milligram per glimepiride, and metformin glimepiride metformin 500 or 1000 combination. No hypoglycemia was observed among these patients. So this is the last part of my presentation. The SAFIS, the Southeast Federation for the use of sulfonylurea recommends on low dose modern sulfonylurea glimepiride, and the best suited for the type 2 diabetes patients in the elderly, in the patient prone for hypoglycemia, in the early stage, which is a mild, if you want the beta cell preservation, the obese or the overweight to avoid the weight gain, and the mild moderate renal impairment to avoid the hypoglycemia. The SAFIS 2015 consensus statement clearly endorses this low dose modern sulfonylurea along with the metformin. So the efficacy of the triple fixed dose combination, we have already discussed that metformin along with glimepiride low dose along with voglibose or pioglitazone we have taken. The more common or more preferred combination is voglibose, glimepiride, and metformin. And this particular combination, twice daily administration in triple FDC category, this is significant reduction of A1C, the baseline to 3 months duration. This is a completion of the treatment and significantly reduced the glycemic parameter as well. So the efficacy of the triple fixed dose combinations, you will see this glimepiride 1, metformin 500 and paglazen 15. It lowers the level of A1C by week 12, and the triple drug resulted statistically superior reduction in A1C, and participants stated that the combination was more tolerable than insulin and the metformin regimen. As we discussed at the beginning, a single fixed dose combination, a single pill intake, a cost-effective molecule, at the same time controlling the diabetes through different mechanism of action is important. So finally, take home will be the dynamics of the diabetes management are changing due to COVID-19 pandemic. We are still not out of the pandemic, and we are passing through the post-COVID or the long COVID time. A lot many patients newly detected and poor controlled diabetes are reporting to us at this phase, and it's important to choose right approach to offer appropriate diabetes care according to your setup. And we have to consider low dose option as an important tool in your diabetes management armamentarium. 0.5 milligram glimepiride we are never giving importance to, but now it is important, because if you don't use that, the sugar will go high, and if it is low dose, it will keep very well control of the diabetes with no risk of hypoglycemia. They are effective, they are safe, they are tolerable, they are affordable, and they are freely available. And we have learned the ideal candidates, the patient profile who will benefit from this newly relevant formulation during this challenging time. So to conclude, ladies and gentlemen, the pandemic has taught us many things like this virtual events, and the pandemic has also taught us that this low dose combination of glimepiride and metformin, the age old partners, can be resourceful during this pandemic time, preventing the hypoglycemia, getting a good A1C, and controlling with a single pill with a good affordability for our Indian patients. Thanks for the time. Thanks for the invitation. I again congratulate team NUCD 2021 for a very successful theme-based, successful and bright landmark NUCD 2021.